Hi, do you want to give them 5 minutes to join, or do you want to just start right away?
Hi, Doc. I think you can be the guiding voice then. Let me know what you think is best. And first of all, can I be heard clearly all around?
You can be heard very clearly. I think we'll start in 5 minutes.
Not a problem.
Mute yourself now.
Good evening, everyone. I'd like to just kindly ask that we all mute our mics. This Zoom session has been set up in such a way that everyone who joins has their mic muted. I see there's an unmuted mic. Can we please just mute our mics to just reduce interference? Thank you. So just good evening to everyone again. I'd like to just welcome everyone who's in this virtual session to another BDU continuous medical education. Today we'll be having one of our special guests and a member of BDU, Dr. Mukondo from the MDR. She's the focal person. She'll introduce herself properly. I don't want to mess up her position and where she's coming from, but the presentation she'll be giving us today is centered around TB management, especially in the pediatric cases. So over to you, Naka. Just introduce. And one thing that I forgot to mention is that this session is being recorded. For those who would like the recording, the link will be provided later. Please may we allow the presenter to present all the way till the end of her presentation, and then at the end of the presentation, that's when we'll take questions. And then if you have any question that is burning, please use the chat function to put your questions there. Otherwise, just wait up until the presentation is done for you to ask your question. So at this juncture, I'll just hand over the floor, the podium to our presenter and our guest speaker.
Thank you so much, Dr. Charles. For those who don't know me, my name is Dr. Makondo. I am the focal officer for drug-resistant TB and childhood TB at the Ministry of Health at the Botswana National TB Program. So today I have had the great privilege of presenting to you on TB diagnostics and treatment. So I've made it as broad as possible and as short as possible so that we can be able to grasp something there instead of boring you with too many slides. And where there is any questions, please do post them and I'll try to address them to the best of my ability. And so without further ado, let me just start. Am I very audible?
Yes.
Thank you, Dr. Charles. So the main objectives of our presentation today, we're just going to be able to try get us to a point where we can diagnose pulmonary and extrapulmonary TB in both adults and children and identify the best diagnostic tools for where we are at a particular juncture, and then also to look at the treatment durations as they are currently. Please note that these are ever changing as guidelines get updated with new researchers and everything. So these durations are what we have currently, and they may be changing anytime. So the TB diagnosis, so just not to bore you with reading you the slides, it is very difficult to diagnose TB in people living with HIV or people who are immunocompromised. So the main thing is with the diagnosis of TB, we depend on the immune system to kind of herd the bacilli to a place where we can be able to get them. Like with the sputum is formed as the bacilli is herded by the immune system into that phlegm that is then coughed up, which is something that is better in HIV negative people than it is in HIV positive people. And then also we have to remember that HIV positive people tend to have what is called paucibacillary disease. It means, basically, it's just the description, it's what I just described. It's difficult for that bacilli to be caught on any kind of bacteriological sample, not meaning that it is not there. And then also people living with HIV, they tend to have atypical presentations on X-ray. If you remember properly the pathophysiology of how the gonfoci on X-ray are formed, one of the key factors that play there is the immune system and the immune response to the TB bacilli. But then in the case of the immunocompromised individuals, it's going to be difficult for those signs to come to be visualized because of the compromised immune system. So also the fact that in immunocompromised individuals, the bacilli tend to be, they are not contained by the immune system in the lungs, as is most common in people who are HIV negative. So HIV negative people, they'll easily be noted if they're pulmonary TB, easily diagnosed, but then extrapulmonary tuberculosis will be more common in people living with HIV, as it has a better chance of just running around and creating havoc. So in people living with HIV, the detection will be delayed and they'll be caught when the disease has disseminated or the disease has now reached extensive damage. So that is why we tend to have higher deaths in HIV positive individuals. Now, something of note here is children under the age of 5 have quite, the immune system is not yet well developed. So it will also be difficult for the same reasons to diagnose them with tuberculosis. And when we're talking about these under 5s, we're talking about the HIV negative under 5s or HIV positive under 12s. So when we're diagnosing TB, one of the biggest screening tools, this is not just in people living with HIV, our biggest tool for diagnosing TB is screening at every point of contact. Especially for people with HIV, living with HIV and pediatric cases, screening is our biggest tool. If you do not suspect TB, you will never be able to diagnose TB because that is where the cases come from. So HIV positive individuals, wherever you meet them, you have to screen them. A&Es, most A&Es that we have had the pleasure of visiting across the country tend to have screening tools that check for TB signs and symptoms, which is quite wonderful. And then also we have to identify presumptive TB cases. So presumptive TB cases, where do we get this from? From thorough history taking. I know all of us suffered during our internship when they were talking about history taking. So thorough history taking can be, is actually very important, as it is one of the things that will raise suspicion for tuberculosis. And then also, once you've identified your presumptive cases, these also include children with malnutrition. This also includes people who are admitted for any kind of respiratory infection, such as pneumonia. So these are also can be classified as presumptive cases. And of note is anybody you suspect COVID-19, you should also be suspecting TB. So that's one problem that we had as the program during COVID, is that we had a decrease in diagnosis of TB, despite a rise in deaths that were later attributed to TB because of the decreased suspicion rate by clinicians. So signs and symptoms of tuberculosis, we're going to be talking about the cough, which is the most common sign of pulmonary tuberculosis. But then for immunocompromised individuals, the cough might not be present. And then in HIV negative people, it will be a cough of two weeks or more. In HIV positive individual, a cough of any duration whatsoever. Fever greater than 2 weeks for HIV negative. Any duration whatsoever for HIV positive, night sweats, weight loss, shortness of breath, chest pains, malaise. Now, of note, signs and symptoms can also be different in times of tuberculosis affecting different regions. We have had testicular tuberculosis in Botswana. We've got adrenal tuberculosis that we have noted. We have had TB lymphadenitis. We've got Pott's disease. We have so many different types of TB that we have noted within the country. So the symptoms would relate to that particular system that is affected as well. So these are just the general symptoms. So a presence of 3 or more of these signs and symptoms, you can consider that a presumptive case and work up for tuberculosis. So now physical exam. Now physical exam is where now most of it is going to be done by us doctors. So we're looking for hemoptysis. This is quite common in TB. There is fever, there's tachypnea, pallor, abnormal breath sounds. This is normal, but then it can be absolutely normal in people living with HIV. And then you can have your neck stiffness for TB meningitis. And then remember that you can have TB meningitis, just like any other meningitis. For people living with HIV, they can present with no neck stiffness, as this is part of an immune response. There might be pleural effusion, but for TB, it's most often unilateral. I'm saying most often unilateral because you can also find it as bilateral. So you can have palpable cervical lymph nodes for TB lymphadenitis. These are the most common that you'll be able to find, but then you can find them anywhere. And just today we had somebody who had inguinal lymph nodes that were measuring about 4 centimeters each. And there was about 4 on each side. So they were quite large. They looked like mini abscesses. So you can have ascites or hepatomegaly for abdominal tuberculosis, a gibbous for TB spine in children. So if you see that picture there, that is what is called a gibbous. So sputum collection. So with sputum collection, when you get the sample, this is not a part that we usually do as doctors. It's usually reserved for our nurses or the HCAs, but please do take your time to look at your sputums. Some people just give pure saliva and they say they gave sputum and we will get negative results. So sputum has to be about 2 to 5 milliliters. And then greater than 10 milliliters is just too much, and then it lowers sensitivity. So the bottle has to be labeled correctly and then ordered correctly as per the system in your healthcare facility. Some people I'm aware are in clinics that do not have IPMS or PIMS, and then they have to order using forms, and that is still fine. And then make sure that they are used in a cooler that has an ice the ice to decrease the temperature so that you preserve the quality of your sputum. So if a patient cannot produce sputum, we usually advocate for sputum induction. There will be some sputum induction machines that will be dispatched by one of our partner programs. I'm not sure how many facilities are receiving this, but it's not all of them. They were decided by the partner programs, not us, so please don't come for me. And then so induction as well, just note that sometimes I have had people who have had success using nebulizers as well, just using sterile water with a nebulizer. For some people that's enough to get a bit of sputum, but then for others it doesn't work. So just as you see fit and try, that can be of help. So one thing that we note with sputums is they can be contaminated. So you find that after you collect your sputum, you can clearly see food particles in your sputum. That sputum is going to be marked as contaminated and you won't be able to have it processed. So ideally, you'd want your patient to have maybe in the morning before when they wake up, before they eat, that is the most ideal. But then in other situations, like in A&Es, we do understand that you can't have that as a possibility, but then do try to at least avoid contaminations that you can see with the naked eye. So one other thing is NTRL has requested that when you're sending sputums for culture, please do send 2 bottles because they sometimes get contaminations, and it's easier if they have 2 samples that then they can process the second sample. And it's still okay if you got only 1 sample. And if you note on the sputum collection forms, there is always space for 2 samples. So that is utterly advised. So keep samples away from direct sunlight. As we know, the Mycobacterium bacilli are sensitive to sunlight and it kills them. That's why we always encourage patients who live, who are at home, to always open their windows and curtains so that the sunlight can actually infiltrate the room and kill the bacteria, the bacilli. So if you keep the sample next to sunlight, or maybe you're doing a lumbar puncture there, and then you're literally doing it at the area with direct sunlight because maybe the lights in your clinic are not working or something. Do have something to cover your sample with, maybe a cloth or maybe one of those sterile cloths. After you get your sample, just cover them just to try preserve those bacilli. So liquid media have a higher contamination rate, and sputum must get to the lab within 3 days. But in some situations, this is extended because some places is very far from the lab. For example, somebody in Shaka, where we cannot expect the sputum to arrive at NTRL within 3 days. It's going to go to Maung first and then be transferred. I don't know how that really works, but then we do understand, but then get it to a lab as they know how to preserve it properly and keep it from getting damaged. And then GeneXpert samples can be kept for a bit longer. This is because GeneXpert is a gene amplification test. It is not looking for whole bacilli. It is looking for remnants of the DNA of the mycobacterium. So in any particular sample, even if the bacilli die, the GeneXpert can still pick whatever is there, the remnants of the DNA, and then amplify that into the diagnosis of tuberculosis. And then extrapulmonary specimens must be submitted as soon as possible after collection. And then also for areas that we use gastric aspirate, we have noted that within the country, we've been having issues with sodium bicarb. So where we're having issues with sodium bicarb, it is utterly useless to use AFB because the gastric acid is going to be working on your sputum, on your gastric aspirate, and then it is going to destroy your bacilli and their cell walls. So doing that, you won't be able to catch anything. So the bicarb actually neutralizes the acid and trying to preserve whatever bacilli are left in there for your AFB. So if you are forced to actually do a gastric aspirate and there's no bicarb, or even if there's bicarb, you have a better chance of getting a positive result using GeneXpert, as it's just looking for the remnants. But then GA, do note, the longer it stays, the less your chances of actually catching anything. So why are we advocating for GeneXpert to be the initial diagnostic tool? GeneXpert is actually more sensitive than most tests for tuberculosis, especially in pulmonary TB and HIV negative individuals. So whereas smear would have been needing a higher bacillary load, GeneXpert just needs remnant of the DNA, which is actually easier to get. And then GeneXpert has a really fast turnaround time, which is about 4 hours. And then one thing of note, please clinicians, GeneXpert does not replace culture. We are aware that it will talk of rifampicin resistance, but then GeneXpert does not differentiate between dead and live bacilli. We can have somebody at the end of treatment having a positive GeneXpert because of the dead bacilli in their system, whereas now the live bacilli would be caught by culture. GeneXpert does not differentiate that. So GeneXpert can only do rifampicin resistance. A person can have any other type of resistance, can be isoniazid monoresistant, it can be any other resistance that does not include rifampicin, so we still need to do culture. For every positive TB case that you get, please make sure that you order a culture and a DST as well. So the drug sensitivity test. So one thing of note is GeneXpert will not be done on bloody specimens. So still just send that one for culture. When you send for a culture, for TB culture at NTRL, they'll still provide you with the so bicarb has been I'm sorry, I was reading a comment there. So, so your bloody specimens will not be processed at NTRL or any other place that they process GeneXpert. They will not be processing it, so they'll divert it to AFB. So please just send for culture in that particular scenario. Moving on. Expert, now as an initial diagnostic test, we know that expert is more sensitive than microscopy. We have already reiterated that, but this is just some of the statistics from the years that we have noted. But then something of note is for the past year, we've been struggling with gene expert cartridges due to supplier issues. So we do know that this particular year, your AFB would have been used more than Gene Expert, except in some facilities where maybe there were partner programs there, but then it was a nationwide struggle. It's not just your facility. So interpretation of the expert results. So what we note is Gene Expert will always say MTB detected, resistant detected. So now when they say MTB detected and they say low or they say medium or they say high, they're talking about the bacillary load in that particular case, the concentration of the MTB in that particular scenario. So where you find it saying low or trace, you have, especially the trace, if it's saying trace in an HIV negative, positive individual, still do initiate treatment. In an HIV negative individual, it says trace, you might want to repeat the test. But then due to the shortage of cartridges that has been experienced nationwide, we tend to say, instead of repeating expert, just send for culture, because cartridges are quite scarce right now. We're still working on rectifying that issue, but then we're still trying to get a new supplier. So the contracts should be finalized anytime now. So now when we're talking about RIF resistance, if it's saying no RIF resistance detected, we know that it's sensitive to rifampicin. You initiate on drug sensitive TB. There is those TB cards in every single clinic. You initiate as per weight category of that patient using your TB cards. So, and then you send 2 samples for culture and DST. And then for RIF resistant not detected, you send, you still send for culture. Any patient who's MTB detected, you send for culture. So RIF resistant is detected, you request direct LPA as well. This is faster than DST after culture. They do the sensitivity test before they do the culture. So of note is, one thing that I always get asked is, why does culture take so long? So they take the specimen and then they inoculate it into mediums that are shown to grow tuberculosis, the Mycobacterium tuberculosis. So they have a marked point where they say, if nothing grows until this point, then the specimen is negative. So that is 45 days for another one and 56 days for the others. So 45 or 56 days. So they have to wait for that 45 days or 56 days to elapse before they can say the specimen is negative. So if it hasn't elapsed, then they cannot say the specimen is negative. So that is why culture takes forever. And sometimes if the sample took long to grow, even if it becomes, they see a growth at day 44, it will still be recorded as positive, meaning that a culture might still take 44 days to be processed. So direct LPA would be done before the culture is done. DST will be done after the culture is done, because now they'll be inoculating that which they have grown into mediums that into the disc that try to see how that mycobacteria is going to react to different drugs. So the DST might also take an extra week on top of after the culture results have been released. So if it's saying MTB not detected, you cannot rule out extrapulmonary tuberculosis if that was sputum. TB might still be there, but not in that particular sample. Okay. Can somebody please mute themselves? Okay, moving on. So if it's saying invalid or error, sometimes it's lab issues, sometimes it's the cartridges or we don't know, but then just repeat the test. There's nothing we can do in that point, just repeat the test. So one thing of note as well, if they say RIF resistance indeterminate, sometimes the sample was too small, or sometimes the bacilli themselves, they were not concentrated enough for them to be able to tell the resistance pattern. So in this particular scenario, guidelines say repeat the gene expert, but because of the shortage, just send for culture with direct LPA. So Now, why do we perform culture? I think we've already talked about this. Culture is more sensitive than smear and gene expert, and it proves diagnosis. And then it can also perform DST. Gene expert does not do DST. And then the duration of culture results depend on the type of method. Like you said, midget is 42 days, LJ is 56 days. And then one thing of note again is those patients that you have diagnosed by AFB. AFB does not differentiate between NTMs or MOT, Mycobacterium other than tuberculosis, also called non-tuberculous mycobacteria. So in the West, they'll say NTM more, but in Botswana, you find that they wrote MOT more often than not. So AFB cannot differentiate between these two. So culture is still important in that particular scenario. So all TB cases diagnosed must have a culture done, with or without rifampicin resistant. So your cases for childhood TB as well, we do recommend that you do culture, as they tend to have possibly disease. Culture might have a better chance of catching the TB. And then patients with suspected extrapulmonary tuberculosis, as culture can be done on almost all fluid samples, whereas you cannot do gene expert on pleural fluid or acidic fluid and all those, you can do a culture on those, and you might have better luck in getting a positive sample there. And then in patients with productive bloody sputums, we still do culture, because any bloody specimen, you cannot do a culture on. So if the culture is saying MOT or Mycobacterium other than tuberculosis, the thing is, it can be a contaminant. MOT is available in our tap water. Everywhere, actually. MOT is available in sand. MOT is a common contaminant everywhere. So it might be a contamination. So for us in our national guidelines, we say for a MOT diagnosis to be placed, there need to be 2 positive cultures 30 days apart with the same species of NTM. So if you're getting a diagnosis that says Mycobacterium abscessus, today, as in the month of May, you need to repeat the culture in June again, 30 days after the first culture, and see if it will culture the same mycobacterium. And if it does, then it is considered a positive MOT case, and then you can refer for initiation of MOT treatment. But then if it's just one isolated MOT specimen, then we consider it a contamination, and then we do not take action on that one. And then of note, people who have recurrent diagnoses of TB, they tend to be more MOT. Majority of the MOT cases that I have seen within the country that I have managed, I think the most I saw was from a clinic in the south. I won't say where because I'll be blasting some people. The man had been initiated on treatment 11 times before in a period of 8 years before somebody decided to do a culture. That is highly unacceptable, and we can get sued for such. So let's not do that. So okay, we've talked about this. The LPA will also differentiate the types of MOT, because different types of MOT tend to require different types of treatment. For example, Mycobacterium chelonae, which is quite common in people who have had like tattoos and everything. It's more common in the West. I think we've only had one case in the country that I know of. That one requires surgical resection. Actually, most types of MOT require surgical resection, as they're quite resistant pathogens. So even if it's in the lung, we tend to want to do lobectomies of the affected lobe to try and decrease the bacillary load. And then we can also do therapy with drugs, and then with also doing physio and all that to try to assist the patients. But MOT gets to be quite a severe disease most of the time, because it's diagnosed late and it is very resistant. So just a second, sorry. So with that in mind, why we perform LPA? So LPA, the direct LPA, although some studies have said direct LPA is not as sensitive as the DST that is done after the culture, it gives us a faster turnaround time. So LPA would give us the results the day off or even the following day before the culture is done. So you might not actually be able to pick an MDR, for instance, way before the culture is out, which is quite helpful for us as the healthcare workers, as we tend to isolate them faster, and for the community at large, and as well for the patient as they can be escalated to second-line treatment faster. So turnaround time for culture, after culture, like we said, is 5 days. So LPA as well can be used to identify MOD cases. It is what is used to identify MOD cases within the country. So direct LPA, all if resistant samples, you request direct LPA. So if you request direct LPA, some people actually, when they're ordering culture, they do not tell NTRL that, okay, this patient was seen with MTB detected RIF resistance or anything like that. They just write sick on their ordering forms, and that is not being helpful to them as they don't know how to best serve us as clinicians. So moving on, comparing smear, expert, and culture. Smear test is quite rapid. It's supposed to take within 24 to 48 hours, but then sometimes with the backlog, and they'll tell you that there's staff issues or other things, it can take longer, but that is not the test itself, but because of the human resources issues surrounding the test. And then it has low level of infection control as the staff actually has to handle and manipulate the sample themselves. And then it has a low sensitivity rate because it needs more than 10,000 bacilli in a milliliter, whereas expert and culture need about 500, but can work off of less. So smear is best for pulmonary TB, and then other samples tend to be quite difficult. And then, like we said, smear cannot differentiate the different species of mycobacterium, whether it's MTB complex or if it's MOD, it cannot differentiate. And then it cannot, of course, tell you if it's any kind of resistance. So we tend to recommend that smear is used for monitoring. So after you've initiated your patient on treatment, you do your gene expert, it comes back positive. You order the culture. At 2 months, at the end of initiation phase, you order a smear. This smear is what is going to tell you whether your patient is improving or not. If they went from smear of 3+ at the beginning, that was reported with the culture, to a smear of 1+, we can conclude that the treatment is working because there has been a decrease in bacillary load. But if your patient was 3+ and there's still 3+ at 2 months, then you should be raising questions. You should be asking questions. And cultures need, you must follow up your culture and sensitivity because there might be an undiagnosed resistance. And a case where we saw this last year, we had a young girl who was referred to Gaborone. She had been having pulmonary, she was 19 years old and treated for TB 4 times, and nobody had done a culture on her. And by the time we saw her, she had already had a collapsed lung, and she was working at about 40% lung capacity, and she unfortunately died because she had isoniazid-resistant tuberculosis. And we thought that with isoniazid resistance, there's usually ethambutol resistance as well, which means while she was on ATT, she was just taking rifampicin and pyrazinamide, just 2 drugs, which is below the recommended number. And then in the continuation phase, where it was HRE, she was literally just on rifampicin alone, which was inadequate for the bacilli. And then she ended up in MDR, and she died because it was caught too late. So gene expert, we've already talked about it. It identifies Mycobacterium tuberculosis using a gene amplification method. Culture, we talked about, takes 1 to 8 weeks. And as a diagnostic tool, culture is not the best. AFB and gene expert are your diagnostic tools. Smear and culture are the best used for monitoring. So now, when we're talking about diagnosing TB in adults, you suspect a TB case. You collect your sample. It can, if it's sputum, CSF, and pus, if they are not bloody, you send them for gene expert. Just 1 sample is most often enough, unless if accidents happen. If it's pleural fluid, peritoneal fluid, bloody specimen, tissue, FNA, or biopsies, they send for culture. But of note, unfortunately, within the country, we do not have the capacity to process culture on solid specimen. So those ones usually NHL does the process, like most of our FNAs, they do Ziehl-Neelsen staining, and then they can help us diagnose TB like that. And then sometimes also you can rely on things like radiographic evidence like ultrasounds. We know that with ultrasonography, you can see any kind of caseous necrotic picture with your ultrasound, and maybe in lymph nodes or anything like that. Then they'll be telling you that it's suggestive of a tuberculosis, or maybe for TB abdomen, you'll be seeing those para-aortic lymph nodes that will tell you that it is probably TB abdomen, and it tends to have an obstructive picture on your blood work as well. So those are some of the things that tend to assist where your sample cannot be processed. So just a summary of what we just talked about. MTB detected, you send for LPA and then culture. No resistant, just culture. They'll do the DST at the end of the culture. So now for TB in children or under 12s. If there are presumptive TB cases, you take your sputum, gastric aspirate, your sputum induction, see whatever sample you do, and then you do for to the peripheral labs. Most peripheral labs have GenExpert machines, so they do the GenExpert there. And then if it's anything else, they're sent to NTRL and they're done culture. Now, and another good news, NTRL is opening a second branch within the country in Francistown. We're hoping that is going to be happening within the next few months. It should be ready soon. So it would also ease the load from the Gaborone lab and also improve the turnaround times for samples that are coming from far to reach areas. And then of note as well as the BNTP, we are launching the stool testing. Stool testing, we have been approved. The trainers came from Atlanta. We have been approved to do stool testing as a country. So currently we are creating a rollout plan to see which facilities we are starting stool testing in, and then and which kind of facilities, how the order of the rollout, how it is going to be happening. So of note, just a little brief on stool testing. This is a test for pulmonary tuberculosis. So the assumption is, if they are coughing up sputum, these young children, they are swallowing it, because most of the time they do not cough it out. So as they're swallowing it, they're swallowing up the bacilli. So we'll be able to get them in stool. So that should help us with the diagnostics of childhood TB within the country, and hopefully we'll be getting better statistics with the children. So pulmonary TB, we tend to go for sputum. TB lymphadenitis, FNA or excisional biopsy. Now, miliary tuberculosis is a type of disseminated TB. So this one we need to do blood cultures. The blood cultures for tuberculosis, the culture bottles for blood for tuberculosis in the country are not available yet, unfortunately. So we tend to diagnose miliary TB just based off of the X-ray. So that is the only TB where we recommend that you see the X-ray, you see miliary pattern, you just start treatment, no questions asked. If you can collect a sample for sputum, then please do. But if you can't collect the sample and you're failing to get anything for sample-wise, do proceed to just your first-line treatment. There's nothing we can do in that particular scenario, but hope we get blood culture bottles as soon as possible. Now, FNAs, if it is not bloody, you can send it for GenExpert, but most of the time it's not adequate enough for GenExpert, so NHL ends up doing ZN staining for us on that. So now we're talking about the types of diagnostic tests to perform in extrapulmonary TB. Pleural fluid, GenExpert is a no-no because it tends to have a low bacillary load, and then it tends to be negative more often than not. So culture is a better option for us. So cytology-wise, you can also get lymphocytic predominance with a protein content of 5 grams per deciliter and high in glucose. That's usually what you get in pleural fluid that is for tuberculosis. And it's usually straw-colored, like a yellowish-looking pleural fluid. That's more often than not tuberculosis. And then pleural biopsy is not done. Actually, the cardiothoracic surgeon has told me about a case where he did a pleural biopsy, so it's available in private, but in government, I'm not aware of any surgeon who does it in the country, so let's say it is not available in the country. Meningitis, CSF, you can do all these tests. As long as it's not bloody, you can do a gene expert. And then in the joints, they tend to do joint aspirations. These are usually our orthopedic surgeons who do this. And then, yes, it can do culture, but not a gene expert. And then cytology and histology, you can do that as well. So now there is one great tool that we have. It's called the lateral flow lipoarabinomannan. So what is lipoarabinomannan? This is a peptide that is found in the cell wall of the Mycobacterium tuberculosis. So this particular remnant of this, it's this peptide, in cases where TB is in the body, TB breaks down in the body, and remnants of this is excreted in the urine. So in people who are immunocompromised, there'll be a higher number of bacilli that are roaming in the body, but not necessarily in one particular area, which is why we expect that the lipoarabinomannan in their urine would be higher. So that is why our current guidelines say urine LAM should be used for an outpatients, people with a CD4 count less than 200. But then in inpatients, we say people of any CD4 count. Whether it's high, whether it's low, if they're hospitalized, you can do a LAM. That is, the saving gram was released. We released it this year, I think it was February or March. So you can still order LAM on anybody HIV positive if they're hospitalized, or less than 200 CD4 count if they're outpatient. So of note is LAM is considered a bedside test, but because of abuse that was happening within the country, there were people who were taking 20 strips, we don't know for what. Strips would go missing, results would go undocumented. So LAM is now done in the lab just for monitoring purposes, but it's still, it behaves just the same as a pregnancy test or any other test like that. So sensitivity for LAM is poor in HIV negative patients because the bacilli tend to be more controlled and more herded. So there'll be less lipoarabinomannan in their urine. So it is used as an initial diagnostic test. You cannot use it at the end of treatment to say, no, I'm checking if TB is still in their system. You cannot use it for that. It's used for initial diagnosis only, just like gene expert. So you can, like now, it's not a replacement for gene expert. It's not a replacement for culture. Nothing can ever replace culture. So you should send sputum samples where possible, or send for culture where possible after you've confirmed your LAM results, and then initiate your patient on treatment. Smear microscopy is still very important. It is one of our best monitoring tools. It is cheap for monitoring and it is easy, and all peripheral labs can have smear microscopy. So treatment regimen, we have two, currently we're using HRZE, which is a combination drug of isoniazid, rifampicin, pyrazinamide, and ethambutol in adults. For initiation phase and then continuation phase, we are using HRE, which is isoniazid, rifampicin, and ethambutol. So for DRTB, we are using new drugs. So I will not go in depth with that one because that's a whole different ball game on its own. We will not be having enough time to talk about DRTB. So that one, there is 6 DRTB sites in the country. We have Gaborone, we have Khansi, we have Maung, we have Francistown, we have Serowe, we have Mahalape. So these are the 6 DR sites. You refer to the one closest to you that is covering your district if you have anybody with rifampicin resistance. So the reason we do that as well is because this helps us monitor and keep uniformity with the treatment of drug resistance tuberculosis. So The duration, currently we are at 6 months and 10 months for TB meningitis and 12 months for joints and bones. This will change as the diagnosis as the guidelines are being updated. So now of note is your pyridoxine dosage. This is something that we have been noting as we are going on in our MSS visits. Pyridoxine dosage is not limited to 25 milligrams. This is meant to help with one of the most common adverse effects that we tend to have is peripheral neuropathy. And this is to help mitigate those adverse effects and help our clients. So this can be increased dosage all the way up to 200 milligrams. That is acceptable. And then if the peripheral neuropathy persists, you can even add things like amitriptyline and gabapentin. That is still fine. So now when do we refer patients to our DR sites? We have anybody with rifampicin resistance or any kind of resistance, we send to our DR sites. And then retreatment failures, we can send to DR sites as well, or complicated TB, usually in Gaborone, they tend to send to DR sites for complicated TB, or if not the DR sites for outpatient, the TB clinic outpatient, or inpatient, they tend to send to the wards for drug-sensitive TB. So these are some of the referrals. And then in the Greater Gaborone as well, for MOT is managed at the DRTB site. As this clinic, TB clinic in Greater Gaborone, Princess Marina with its high load have designated it as running the whole week with Mondays and Thursday running for MOT and complicated drug-sensitive TB, and Tuesday and Thursday being reserved for Tuesday and Wednesday being reserved for drug-resistant tuberculosis, and then Fridays being reserved for their inpatients. So these are just some of the contacts of our DRTB sites. Just take a screenshot. It might be helpful. So for monitoring, as doctors, we need to be monitoring for adverse effects. If you be able to monitor for your adverse effects, most people who default are defaulting because of adverse effects. So if you monitor properly for your adverse effects, then you have a higher chance of your clients actually completing treatment, because that is going to be easier on them. They know what to expect. So when you are monitoring, one thing you are noting, you want to make sure that your patient is no longer infectious, they're no longer a public health threat. And then are they responding to treatment? This one we usually also look at their weight. Are they gaining weight? And then also looking for any kind of adverse effects. And then this can be done, monitoring, we do it clinically by just looking at your patient, talking to your patient. We do it bacteriologically with your AFB at the end of treatment. You can do radiological studies with your X-ray to see if there's an improvement in the X-ray picture. And then, but we rely mostly on sputum conversion for pulmonary tuberculosis. And then, so the symptoms should improve while you are monitoring. The weight loss should be improving. The fever should be improving. Night stress should be improving. And then adverse effects, like I have already noted. Peripheral neuropathy is one of the most common. And then one thing is we have recently received 5 cases of very disturbing cases where people actually lost their vision. They told their doctor that they were having issues with vision, and the doctor told them, oh, that's just TB, continue drinking your tablets. This is poor practice. We need to be monitoring and noting any kind of adverse effects and trying to remove the offending drug where possible. So now the weight, as your patient gains weight, you adjust the dosage with the patient's weight. So sputum smear should be obtained at month 2 or 3. That is at the end of your initiation phase. And then at 5 to 6 months, usually we say you can do a culture if the smear was questionable at month 2 or 3 there. And then you can just do a culture at the end to make sure that there is no live bacilli. But then if the smear had been negative, you can just repeat the smear at the end of treatment. That's still fine. And then you must document. We know that in medicine, we say not documented means not done. So this is just, we're saying 2 months. It's we just, that's how we respond to that particular microscopy results. So at month 2, if microscopy is still positive, you continue with the continuation phase, but then you repeat it at month 3. At month 3, if it's still positive, you continue, but then you do culture and DST. And then if it's any resistance, you send to the DR site for initiation of second-line treatment. The initiation, we have centralized it for ease of monitoring. Bedaquiline and the other drugs that we use for second line are quite expensive, and they were quite abused when they were left decentralized, and people were using them to treat other things and experimenting with them on other conditions. So they were centralized, and some of them are only released on a patient basis. Like bedaquiline, if we don't have the patient's card, we will not release bedaquiline. So of note, GeneXpert is the initial diagnostic test for TB. All bacteriologically confirmed TB cases must have specimens sent for culture and DST. RIF resistance must be documented. And then TB-LAM is a good diagnostic tool for TB in immunocompromised individuals. Expert and LPA are not used for treatment follow-up. They are used only for diagnostic. Even LAM is used, not used for follow-up, but for diagnosis. And then all TB patients should be monitored and evaluated at the end of their treatment. So that will be the end of my presentation. Before we move on to comments, may I just address the ones who have posted in the comment section. We have the incidence of urogenital TB in Botswana. From what I've seen, I think I've seen 3 cases that were reported to me personally, but then I haven't seen any other of those because there's very low suspicion for those. But then if there's a higher suspicion rate, I think would get more cases. And then we have a challenge calculating doses for PEDS patient, no ethambutol. The drug cases has been an issue in Botswana, yes, but then we're trying to rectify that. Currently, there is isoniazid and rifampicin, the dispersible doses. Ethambutol has been a bit, there's been a shortage of that. Ethambutol and clofazimine for the DR-TB patients, but clofazimine arrived this week. And then if your facility does not have clofazimine for the DR sites, please request, we've asked them to order it as an emergency order. It will be delivered to you. It is available in the country. And then Dr. Jonathan, we are aware of your opinion, sir. Thank you so much for your comment. Moving on, is there any other questions, comments? Okay, is DR-TB infectious once converted? So DR-TB, we say if it's sputum negative, it's not infectious. Like DSTB, we say after they take for the first 2 weeks, they can start mingling with the community, it's fine. For DR-TB, it's only after they have confirmed sputum conversion. And sputum conversion for DR-TB, we say it has to be 2 consecutive negative results, which means a DR-TB patient can be on isolation for up to 6 months, unfortunately. But then it's a higher public health concern, so we have to be more strict with it. Are there any other questions? Do we have questions, colleagues? Dr. Charles, are you still online?
Yes, I am. I'm actually shocked that there isn't any more comments or questions from the floor. I know people have a lot of questions regarding some of the cases they've seen. Are you going to be able to share the slides with everyone?
Yes, I will send them to you. Or I'll just post them in our groups. That's still fine.
Great.
Oh yes, there's this people, somebody asking if DR-TB can be admitted to the general wards after conversion. Yes, they can be admitted to any ward after they have converted. That is fine. So yes, no, DRTB, once they have converted, they can be admitted anywhere, anyhow, as long as you saw that there is recent conversion results, and then you are sure that they're not defaulters. Because sometimes you'll say, no, this person converted, but then they have defaulted. So please, on their cards, the DRTB patients, there's also always the contact number of the facility where they are from. So you can also just call and confirm this patient we have here, are they still on treatment properly or anything? The DR sites are always quite helpful with that particular information. Thank you so much, Dr. Gallagher, for that question.
Great. Any more comments?
Good afternoon. Or good evening, I should say.
Good evening, Doc.
I do have a question. So if a patient had been put on ATT, and as a clinician, you are reviewing this patient maybe after a month or two, and you don't know why this patient was put on ATT, and the patient comes without the blue card fully completed, how would you approach that? How would you deal with it as a clinician? Because we come across these kind of cases more than once, and especially in the peripheries.
That is very common. I agree with you. That happens a lot. That people actually, brings us to something. People tend to do this thing where they say trial of treatment for TB treatment. We do not do trial of treatment in TB therapy because most people have latent tuberculosis. So if you are going to be exposing their bacilli to the drugs, and then you give them this treatment for just a short time and then you stop it, you are giving those bacilli a chance to mutate and become resistant to our first-line treatment. So we do not do trial of treatment in Botswana, and we do not stop treatment unless if it's for severe adverse effects or if it's to convert to a different type of treatment. So once they're started, they have to finish.
Hello.
Yes.
Yes. I also have a question.
Yes, sir.
In the region that I'm in, we do get a lot of TB positive clients that are negative, and majority of them, unfortunately, would have post TB structural lung disease. Not sure if it was due to poor compliance in the past or so. Now, I was wondering, when such clients, because of the prevalence of TB in this region, is it possible when we have TB structural lung disease from a primary from before to do a culture while in waiting, even though the symptoms are in keeping with the disease process itself? Can we do a culture while in waiting, or what will you propose? Because I get a lot of post-TB structural lung disease, and the clients will present with symptoms suggestive of, and then there's always a question of, should we still wait, or can we just do a culture while we treat for other pathogens that could cause it? I don't know what's your take on that.
So most of the cases that I've seen that you're describing, Doc, it tends to be MOT more often than we would like to acknowledge. So with that, it tends to be a problem, because if it's MOT, then you just expose your patient to a heavy treatment for nothing. But then sometimes this is where we say clinical judgment is also very important, because on one hand, if it is MOT, you'd have put your patient through the treatment that needs, it would be similar if it's MOT, but then it would have other things like either azithromycin or clarithromycin or amikacin, depending on the type of MOT. And then on the other hand, if you're not going to be treating and saying you're waiting for a culture, you could potentially risk losing your patient. So sometimes with your clinical judgment and seeing your patient's history, if it's the secondary treatment and you feel like it has recurred and it's a treatment failure, you have to request a culture with a direct LPA, because LPA will help you differentiate that faster. And then in the meantime, if you are sure that this could be a mycobacterium patient and there's no chance of getting AFB, because AFB is a few hours and there's no chance of gene expert, then just initiate. But if you have the ability, please push for diagnostic tools, urine lamp, diagnostic tools, gene expert diagnostic tools like AFB, or where gene expert is our primary, like top of the note, what we recommend the most. But then also international guidelines have been updated to include CRP. That's still yet to be, it is yet to be approved for us by the powers that may be. We cannot do any updates in guidelines without HS signing it off, and HS signing it off is a process in itself. So CRP has been shown to be quite helpful, and other tests like your ESRs as well. They're not used to rule out TB. Just because maybe a person has a low CRP, a normal CRP, does not mean they do not have TB. We use it as a rule-in test. I hope that is quite understandable.
Yes, ma'am. No, you have answered a few questions that I had. And just to note that once the stool TB test arrives, please do not forget some of us to spread the word around, because we have a problem when it comes to pediatrics. So thank you very much for your presentation.
Stool TB, yes, stool TB, the trainers of trainers have been trained. They've completed training. And now it's not a problem, but now we are planning on who gets to be the rollout plan, because we have to roll out in a way that we access majority of the country as soon as possible, and also for the gene expert cartridges, because the supplier we had, I'm not sure if I'm allowed to tell you this, but anyway, the supplier we had, we would order 200 boxes, they would deliver 40. We would order 300 boxes, they would deliver 20. So that was the situation we were in. Their contract has ended, they have been terminated, and there's a new supplier who's supposed to start supplying very soon. And hopefully, because they're new, they will be safeguarding their contract very well. So that should be quite helpful. Any other questions, please?
Thank you. I'm not sure if I understood the question, that the answer to Sanola's question regarding patients who seem to always test negative. I don't know if I understood. Did you say that most likely they would have MOTT?
Yes, most likely they would have MOT. You're saying they always, no, what I understood Dr. Tsenolo to be saying is if they tend to test negative post-treatment, but then they still look like they have the symptoms, even though they were treated. Yes, so that's where I was saying it's either going to be either a resistance or just not the right species. So that's one thing we should really fight to try find which one of those it is. You get?
Okay,
yes.
No, I get. But do we have statistics to say these percentage of these patients would most likely have MOTT?
Unfortunately, we don't have more statistics. I know that I usually talk more about Princess Marina because I used to man that clinic. In Princess Marina, we have since 2019 about since 2020, we've had about 40 patients, greater than 40 patients who were treated with MOT. But then according to NTRL, there has been a lot more cultures that were positive, that they were saying they are sure it's not a contamination, but then the patients were never followed again. The thing is, MOT can still be present in a person without it being an active disease.
Yes, I was going to ask about that.
Yeah, because mort is a common contaminant. It's in tap water, it's in soil, it's in everything. So it can be mort, but it might not need to be treated at that point in time because it's also considered non-infectious. So even if somebody has mort, doesn't mean you're going to tell the family to isolate them.
Okay.
Yeah.
All right. And then as a follow-up to the statement on the stool testing, can I make a suggestion that you prioritize the people out in the peripheries? Please.
If I had the power to do that, I would. Unfortunately, I do not have the power to do that. But then the powers that may are actually looking at that. The thing is, the rollout plan has to be in such a way that we create the biggest impact in the shortest amount of time. So I would bet my money on probably the most highly dense, the most highly populated areas would be targeted, followed by the areas with the most TB concentration, places with a higher TB concentration. That's what I'm thinking is most likely going to happen, but I do not have the facts to verify that.
All right. The other day there was a question, I don't remember if it was in a morning meeting or one of the other presentations about training for TB management, like something like what you've done, but on a larger and more in-depth. Because we've had gizo training, we've had pediatric gizo, we've had EMONC, but majority of us have never ever had a TB training workshop, and a percentage of us studied abroad where TB is just a thing that you hear about, like there'll be a 30-minute lecture on TB and that's it. But we're here practicing in a highly TB country, so maybe take that as well into consideration when you're planning your trainings and workshops.
That is true. Most people tend to be not trained. So most trainings that were done, we had the problem of facilities sending the same people. You'd find a TB coordinator or a particular nurse being so frequent that you know them on first name basis. So trainings have been decentralized. So facilities have votes for training. So what we have requested is facilities to group people in their particular location, and then they call us to come and train. Because that way we are sure that we are doing what is going to bring change to that facility. Instead of just calling one or two people and then that person, they just take it as a free vacation. But if we actually go to that facility, we know that we are actually going to be creating change. You get what I'm saying? So now, for example, we went to Khanzi beginning of the week, and in Khanzi, they said they want a training. They're saying they're going to schedule a training for themselves. And then they told us they will give us the days when they are going to be there, and we will be there to support as the TB program. So that is what we're advocating for, because one, that actually allows us to access more people in that particular district. And two, that actually allows us to tailor make the training to suit that particular district's capacity and their needs. For example, a district like Khanzi will need things a bit different from a district like Gaborone. Whereas Khanzi, they have issues so that Gaborone cannot even fathom. They have this language barrier. There was a client who did not even speak a lick of Setswana, speaking pure Sasaro. I was so confused. I did not know what to do. But then those are some of the things, because TB care is not just about treating the mycobacterium, but it's also a holistic thing where we also have to consider the people that we are dealing with and their tendencies and what they tend to do and how to best approach that. So in the training, we also have to consider that as well.
Wow, awesome. That sounds great and good to know. Everybody has heard that we can set up our own trainings and call you to come.
Yeah.
Thank you so much.
You are very welcome.
Yes, Dr. Makondo.
Ra?
Hello.
Can
I comment? Can I comment?
Yes, I'm not sure who is talking though.
Oh, Mr. Lavala and BNTP.
Oh, hi, LB.
Yes.
Yes.
Yes,
For those who
I
don't
think
know, Mr. Lebalang is with the Botswana National TB Program, and he is one of the officers there, and he would also, so he'll comment there.
Oh, thank you. I think there was a question which was asked that I don't know the third or few minutes back. Even though I didn't pick the question well, I'm looking at the point number 2 that all bacteriologically confirmed TB cases must have specimens sent for culture and DST. So the other important thing which I want our colleague here to note is there is a negative algorithm. If you look at our algorithm, we have got clients where we test them for TB using the gene expert. When the gene expert is negative, for people living with HIV, you must collect another sample, which is for culture and DST, because like Dr. Makondo was saying, it's difficult to diagnose TB among people living with HIV. So thank you. I wanted to stress that point, that any sample which is negative due to gene expert among people living with HIV, we must collect another sample for culture. Thank you.
Yes. And I'm seeing Dr. Mudongo here saying, thank you for the excellent presentation. Any thoughts on Dr. Stryker's comment regarding adoption of the new WHO short course ATT? So at every presentation that we have done, Dr. Stryker has brought this up, and we have said the same exact response. We cannot adopt new things without actually having them approved within the country. And I have been stressing this more often than not, even when I was talking about any kind of changes that happen within our guidelines. They have to be approved for the country, and then not everything that is recommended. If you look at the WHO strategy, they talk about development. This is where you adopt, but then you modify whatever is being recommended for your particular country, depending on your financial and your capacity and your ability to build up on what you're going to be pushing. So everything that is implemented has to be approved. It is a process. Just because WHO says this is the new guideline does not mean we are going to start it within 2 weeks. We are going to be looking at it and see how it best suits us. And then after that, recommend to those higher than us, and then the ones in charge of the whole ministry. And then once they have approved, and only once they have approved, can we push anything forward. Thank you so much. I hope that covers that question. Will there be any other questions? So in the absence of other questions, I would hand over back to Dr. Charles and say, thank you so much for your attention and your attendance. It is a pleasure to serve you all. Thank you.
No, thank you so much, Dr. Makondo. Thank you for taking your time to give us this excellent presentation. I'll just use this opportunity also just to thank everyone who was present. I see that they've already started logging out. So I'll just say, just in short and quick, that we'll try to be having these sessions every Wednesday at the same time as today. The sessions are recorded, so the recording will be made available. I will just remind Dr. Makondo and her team to just share with us the slides so that we're sharing the recording. We will then share the slides too in those platforms. We will make strides or improvements to try to incorporate the sessions onto a certain platform, for example, YouTube, because they're very important. If there's anyone who feels like there's a presentation that they would like to give that will benefit doctors within Botswana, they can contact me or contact the union. Let's continue to join this great union of choice. Otherwise, it's a thank you again, Dr. Makondo. and a good night from the BDU executive.
Boroko bogoge.